Good evening, everyone. Welcome to IPNA Webmaster Series 2020. Now we have successfully completed 22 webinars and we have stepped into 23rd one. And so today we have four eminent speakers like Dr. Rajiv Sinha, Dr. Chandrasekaran, Dr. Naresh, and Dr. Karthik Mathivanan. And so Dr. Rajiv Sinha is going to be the moderator of the day. Dr. Rajiv Sinha is a certified pediatric nephrologist and fellowship in pediatric nephrology from Canada. He is a professor of pediatrics and he is the head of Department of Pediatric Nephrology at Institute of Child Health from Kolkata. He is also a consultant pediatric nephrologist at Apollo Clinicals Hospital, Kolkata. His special interest is towards renal replacement therapy, including transplantation, and he has got special focus on ABPM. And he has got multiple awards and honors to add to his credit, and would like to read out only few. He is a recipient of multiple travel grants from various societies. He is a member of ISPN, IPNA, ISN, and RCPH. He is also an International Society Nephrology Educational Ambassador, and he is received a honorary membership as well. And he is a International Pediatric Transplant Association mentor for publication. He has got a lot of national and international journals to add on to his list. Over to Dr. Rajiv Sinha to introduce all the speakers for the day.
Thank you very much. Am I audible?
Yeah, you're audible,
yes?
Sir.
Okay. Thank you very much. At the start, I'd like to thank Dr. Namalwar sir and express the fact that as far as Dr. Kalaivani is concerned, I am now a big fan of her because of her perseverance in undertaking this prolonged educational session over this last couple of months, and her perseverance in making us educated. So without wasting much time, we today have a very important series of lectures, primarily focusing on something which is quite, I personally feel, is quite complicated for nephrologists, and that is primary hyperoxaluria and nephrolithiasis. So at the start, to give us a medical input on primary hyperoxaluria, we have got Dr. Chandrasekaran. He is the senior consultant and clinical lead in MGM Healthcare Private Limited, and he has got a specific interest in liver disease associated kidney disease. So he is the right person for this. So Dr. Chandrasekaran, it is all yours if we can start with the talk. Thank you, sir.
Thank you, sir, for a brief and nice introduction. Again, I completely second what he has told about Dr. Kalaivani. Has been toiling for the past 2.5 months to make this program. It's not easy to coordinate such a lengthy program, and she is doing a very good work. And also thank Dr. Namalwar for this invitation to be part of this program. Primary hyperoxaluria is one of the most common metabolic diseases, metabolic renal stone disease, what we see in the childhood. It has got a multivariate presentation, right from nephrocalcinosis to renal stone disease to systemic oxalosis, and a lot of recent ongoing trials probably may open the gates for future therapy. For the next 15 to 20 minutes or so, I just cover on the basics of oxalate metabolism, glyoxalate metabolism, and its effects of hyperoxalosis on the kidney, on the systemic organs, and what are the options available to minimize the oxalate load, and what are the treatment options available. It's not moving. Oh. So it is an autosomal recessive inherited disease caused by several possible enzyme defects and result in endogenous overproduction of oxalate with excessive oxalate excretion through the kidneys, leading to nephrocalcinosis, recurrent stone formation, progressive renal failure with ensuing systemic oxalosis. Oxalate at physiological pH, it forms soluble salt with sodium and potassium and insoluble salt with calcium and as a calcium oxalate. And it plays an important role in plants. It's used as a calcium sink, that is excess calcium absorbed from the groundwater is being absorbed by the oxalate present in leaves, fruits, nuts, and barks. It has some various varied metabolic and homeostatic mechanisms in fungi, bacteria, as well as in animals. In humans, oxalate have no substantial beneficial role and acts as a metabolic end product like uric acid. If not for oxalate's high affinity for calcium with attendant low solubility of calcium oxalate, and oxalate metabolism would be of little interest. And it is absorbed primarily from the colon from dietary sources. So the major source of oxalate in humans is from the endogenous source from the metabolism in the liver. And in the kidney, it is secreted in the proximal tubule via two separate carriers involving sodium and chloride exchange. Oxalate, as we know, is a metabolic end product of known use in humans. And the most important precursor of oxalate in humans is the intermediate metabolite glyoxylate, which is synthesized from glycolate by the liver-specific enzyme glyoxylate oxidase. The source for glycolate is again is unclear. It can be from the plant sources or it can be from the dietary carbohydrate precursors. The glyoxylate undergoes detoxification by transamination with the help of AGXT enzyme to glycine, or it is converted to glycolate by GRH, glyoxylate reductase in the cytosol. Glyoxylate reductase is present both in the cytosol as well as in the mitochondria. It helps in reducing the glyoxylate to the glycolate. In the absence of transamination of the glycosylate or the reduction to glycolate, the LDH actually promotes the conversion of glyoxylate to oxalate, leading to oxalate in the plasma. And again, from the collagen-rich dietary sources leads to hydroxyprotein, which again broken down into 2-hydroxyglutarate, which is again metabolized, which is again undergo in the presence of HOGA enzyme to glyoxylate and pyruvate. So the primary oxaluria primarily occurs because of disorders of glyoxylate detoxification mechanism. There are three types based on the enzyme. The type 1, which is more common, which is because of low or decreased activity or misdirected activity of the liver-specific peroxisomal enzyme AGXT, alanine glyoxylate transferase, leading to excessive accumulation of glyoxylate and excessive production of oxalate and glycolate. And lack of glyoxylate reductase again leads to excessive oxidation of glyoxylate to oxalate. And type 3 is associated with deficiency of OGA1 enzyme. We don't know why, it's still unclear why such a deficiency of that enzyme causes elevated oxalate levels. So usually in the absence of AGXT enzyme, there is excessive oxalate production by the liver, and it couples with calcium to form insoluble calcium oxalate, which in the presence of normal kidney function, this calcium oxalate gets deposited in the kidney and forms nephrocalcinosis, parenchymal calcification, and then it can also form calcium oxalate stones. As the disease progresses, as the leading to damage to the kidney, and the GFR becomes less than 30 to 50, that is stage 3 chronic kidney disease, there is supersaturation of the plasma with oxalate, leading to systemic deposition of the calcium oxalate crystals in various organs, in the vessels, in the bones, in the joints, in the retina, as well as in the heart. So any patient the patient profile in PH1 can be of the 5 groups, falls into 5 groups, can be infantile hyperoxaluria with the early nephrocalcinosis, renal failure in childhood, can have recurrent nephrolithiasis, progressive renal failure from childhood to adulthood, and can be first diagnosed at ESRD stage by biopsy, or we can identify when the patient has recurrence of oxalate nephropathy in the transplant kidney, or it can be a systemic oxalosis which manifests first during dialysis. Sometimes there may be late onset form with occasional stones diagnosed in adulthood, or it can be pre-symptomatic, diagnosed in individual because of a positive family history. So I just go through a case presentation, and then we discuss how we can approach a case of suspected primary hyperoxaluria. This is a 9-year-old boy who presented in 2017, who is born of 3rd degree consanguineous parentage, admitted with complaints of dysuria and hematuria for 2 days. Going to the previous history, the patient was noted, the child was noted to have clustered calcification in the projection of the kidneys in the kidney area, suggesting medullary nephrocalcinosis. This was an X-ray taken for some fever and presumed chest infection. At 8 months of age, in the year 2008, he presented with acute abdomen due to intussusception. Pneumatic compression was done. His ultrasound at the time reported as diffusely increased echogenic fluid suggestive of medullary nephrocalcinosis. At 4 years, 9 months of age, his creatinine was still at 0.7 milligram, and USG KUB showing hyperechoic pyramid suggestive of medullary nephrocalcinosis. He was not on any medications at that time. At the age of 6 years in 2015, during follow-up with a pediatrician, his creatinine was around 1.1 milligram per deciliter, and he was on potassium citrate, bicarbonate, and calcitriol. Just 2 months prior to 2 to 3 months prior to this admission, he had his urinary calcium estimation done, which showed around 101 milligram per 24 hours. He was weighing around 28 kgs at that time, and it is close to the upper limit of the normal. On examination at presentation, he was built normal for his age. He was normotensive, and on evaluation found to have urethral calculus just proximal to the external urethral meatus. His serum creatinine was mildly elevated around 1.56. He had hypovitaminosis, and urine culture was sterile. So the ultrasound at the time showed a kidney size of around 7.5 and 7.8 centimeters with increased echoes. As usual, he had hyperechoic renal pyramids. Suspicion of few calcial calculi was noted, and pelvic system was normal, and right vesicular junction was prominent. So the boy was planned for cystoscopy and stone retrieval, but luckily he paused the stone on his own, and the stone was sent for chemical analysis, which revealed calcium oxalate stone and as well as non-calcium oxalate in the chemical analysis. So he was discharged with syrup, potassium citrate, vitamin D, tamsulosin, and for OPD follow-up, he was advised to work up for possible primary hyperoxaluria as outpatient. So does this boy has primary hyperoxaluria? What are the suggestive findings to show that he has primary hyperoxaluria, and how can you establish the diagnosis if you have some suggestive findings? So this is a simple pictorial table which we normally follow. The patient can present with a normal renal function or with chronic kidney disease. When you suspect primary hyperoxaluria, if a patient normal function presenting with recurrent stones as well as nephrocalcinosis in childhood, or with a family history of primary hyperoxaluria, then once the patient has got recurrent stones or nephrocalcinosis, you go and estimate urinary oxalate. urinary oxalate more than 0.7 millimoles per 1.73 meters squared per day, or urinary oxalate were creatinine more than normal for age, which should be confirmed or repeat testing, suggest urinary oxalate, then go ahead with urine glycolate and L-glycerate, which is not easily available. If the patient has got chronic kidney disease associated with calcium oxalate tone or with CKD with calcium oxalate deposits, especially in the retina, or when you do a AV fistula, you can sometimes find calcium oxalate crystals, or chronic kidney disease with attendant nephrocalcinosis. Again, you suspect primary hyperoxaluria. The patient with CKD, if the urinary oxalate is more than 0.5 millimoles per liter per 1.73 meters squared per 24 hours, or measure plasma oxalate more than 20 micromoles, it suggests primary hyperoxaluria. And then you go again to confirm it by a molecular testing for mutations in AGXT, GRHPR, OHA1. At the same time, you have to rule out other secondary causes which comes into the differential diagnosis. Look for malabsorption, gastrointestinal disease like Crohn's disease or cystic fibrosis, and a patient on very high oxalate-rich diet, or in a very infant with prematurity. So all these has to be ruled out. Once the molecular testing is done, you can categorize roughly whether it is primary after 1, 2, and 3. If the molecular testing is negative, then you have to plan for a liver biopsy to look for enzyme activities. So this is the oxalate normal. It's a company slide just for reference. So you suspect primary hyperoxaluria in a patient with a normal renal function when the urinary oxalate is more than 0.7 millimoles per 1.73 meters squared per 24 hours. And in the background of kidney disease, urinary oxalate more than 0.5 millimoles per 1.73 meters squared 24 hours, or if the plasma oxalate is more than 20 micromoles per liter, suggests primary hyperoxaluria. So this boy on estimation of 24 hours urinary oxalate showed a urinary oxalate excretion of 159 milligrams per day, which is very high. So again, we went it for molecular diagnosis, which showed AGXT mutation. Usually it's a duplication of lysine with glycine, and it's really pathogenic. It is definitely a pathogenic variant suggestive of PH1 type. So liver biopsy is not usually being done because the molecular diagnosis facilities is easily available today. You do only in the presence of hyperoxaluria when this urinary glycolate or glycerate or HOG or DHG are normal, or if the pathogenic variants are not identified on molecular diagnosis. So what is the natural progression of primary hyperoxaluria? Natural history of untreated PH1 is one of progressive decline in renal function because of calcium deposits in the kidney tissue with complications of nephrolithiasis leading to obstruction, infection, and ensuing systemic oxalosis. And probably progression to renal failure is again correlates with urinary oxalate excretion rate and with nephrocalcinosis. And there are some pathogenic variant associated with a milder phenotype with a lower urinary oxalate excretion, better responsiveness pyridoxine treatment, and later onset of end-stage renal disease. What next? Once evaluation following initial diagnosis in patients with preserved renal function, you can do probably periodic ultrasound and fundoscopic eye examination to identify the presence or extent of oxalate deposition. Also, patient needs a baseline urinalysis with measurement of oxalate and creatinine, preferably a 24-hour collection periodically. If the patient is having a GFR of less than 10, in addition to the above, you can go ahead with measurement of plasma oxalate to know the amount of supersaturation of plasma with calcium oxalate. For those with GFR less than 30, or in those with rapid deterioration of renal function, you go ahead with bone X-rays to rule out oxalate osteopathy. Hemoglobin, most of these patients will also have a major deposition of oxalate leading to anemia, even erythropoietin resistant anemia, and bone marrow examination may be needed in some individuals. ECG to evaluate for AV block, echocardiogram to rule out oxalate cardiomyopathy, usually a restrictive type or reduced ejection point is more important when you are considering combined liver kidney transplant. Ultrasound to look for calcifications of the heart and viscera, ultrasound of the abdomen, CT scan, and physical examination to assess the risk of arterial insufficiency or ischemia can cause digital ischemia in case of severe vascular calcification, and thyroid function testing as usual. So once the diagnosis is established, how do you treat? So there are different modalities. One is to reduce the urinary calcium oxalate supersaturation, and the stone is there. How do you treat the kidney stones? And how do you go ahead with reduction of oxalate biosynthesis? Then once the patient is with GFR is around 20 for dialysis, and you have to consider for organ transplantation. So hyperhydration with fluid intake of 2 to 3 liters per meter squared per day. Small children may need NG tube or gastrostomy tube for feeds and fluid supplementation, especially in the immediate post-op period. Alkalinization of the urine to pH around 6.2 to 6.8 to inhibit calcium oxalate crystallization, usually with potassium citrate at a dose of 0.1 to 0.15 milligram per kg in 3 to 4 divided doses. When the GFR is reduced, or if hyperkalemia is there, you consider switching to sodium citrate. Other calcium oxide crystal inhibitors like orthophosphate at dose of 30 to 40 milligram per kilogram per day in divided doses, or magnesium oxide at 500 milligram per meter squared per day can be added upon. So excess oxalate in primary hyperoxaluria is derived mostly from endogenous metabolism, and dietary restriction is of little benefit. The principle of careful food choices is appropriate without much strict limits. High dose of pyridoxine, pyridoxal phosphate is a coenzyme of AGT, promotes the conversion of glyoxylate to glycine rather than to oxalate. At a dose of 5 to 20 milligram per kg per day, we give a positive response is attributed by 30% reduction in urinary oxalate excretion. And of all these different pathogenic variants, 30% of patients with primary hyperoxaluria may respond to pyridoxine therapy. A trial of minimum of 3 to 6 months is warranted in all patients with primary hyperoxaluria. And once the patient is responsive, it should be continued indefinitely or until liver transplantation is performed. Serious adverse effects with high dose of pyridoxine is usually a sensory neuropathy, and is usually reversible on reduction of dose on cessation of therapy. Probiotics that can break down oxalate has been tried in promoting intestinal oxalate excretion. There was earlier small pilot study way back in 2010 and 11, where the reduction of urinary oxalate was noted in 4 out of 6 patients, and normal renal function was achieved over a 4-week course of Oxalobacter formigenes. Subsequent trials were largely disappointing. There is a recently published paper in pediatric nephrology in February 2020, where the Oxalobacter formigenes combined with intensive dialysis has lowered the plasma oxalate and altered the disease progression in patient in a single child with infantile oxalosis. There are a lot of drugs on trial. The most promising one is lumasiran, which has recently been approved by FDA on November 23rd, and probably it is going to be useful for commercial purpose probably in first week of December. So lumasiran is a subcutaneously administered small interfering RNA. What is this RNAi? Is interfering RNA is a natural pathway involved in regulation of gene expression by potentially targeting and silencing messenger RNA precursors that encode for a particular disease or disease pathway proteins. This lumicinon targets the messenger RNA for liver hydroxyacid oxidase, which encodes glycolate oxidase in the liver, decreasing production of glycolate oxidase and hence reduces hepatic oxalate synthesis. And it has passed the phase 3 trials and is going to be and has been approved. There are 3 trials: Illuminate A, Illuminate B, and Illuminate C. Illuminate A is tried in adults and children more than 6 years. Illuminate B is less than 6 years old, and Illuminate C is patient with significant renal dysfunction. So all these patients, it's a multinational double-blind randomized control trial with lumicinon Q monthly for 3 loading doses, followed by quarterly doses at 3 milligram per kg. And what is observed is a significant reduction in urinary oxalate related to baseline, 65% versus 12% in placebo. And at the end of 6 months period, around 84% of the patients had urinary oxalate levels at or below 1.5 times the normal limit. And more than 50% of these patients had normal urinary oxalate levels over the study period. And safety profile is encouraging with only minimal injection site reactions like erythema, pain, pruritus, and swelling, and no severe or serious adverse effects are reported. And Illuminate B was studied in children with less than 6 years with GFR more than 45 ml per minute, and they have noted 100% mean reduction in spot urinary oxalate creatinine ratio from baseline at month 6, and 50% of the patient achieved urinary oxalate levels at or below 1.5 times the upper limit of normal. Illuminate C, the result is not yet been published. It's done in patients with significant renal dysfunction less than 45 ml per minute, both adults and children. And again, dosing is based on the weight. The primary endpoint is the percentage change in plasma oxalate from baseline at month 6. And secondary points includes the changes in the plasma oxalate, urinary oxalate, renal function, frequency and mode of dialysis, frequency of renal events, and measure of systemic oxalosis. So once the kidney stones is formed, previously a lot of patients subject to ESWL, but it is better to be avoided in calcium oxalate stones in primary hyperoxaluria. Minimally invasive urological procedure, RIRS and PCNL is the one which is been advantage and also may be helpful in nephron sparing treatment. So this patient was counseled regarding the nature of the disease, likelihood of progression of the disease, need for regular follow-up, and some diet adjustment with medications consisting of high-dose pyridoxine, potassium citrate, calcium carbonate, magnesium oxide, and sodium bicarbonate. Recently, a month back, the boy presented with severe renal failure and hyperkalemia. Creatinine has been stable for the past 2 years with creatinine at 2.6 milligram in end December. But now he presented with severe hyperkalemia and severe renal failure, and he was noted to have high blood pressure, and he was started on hemodialysis after temporary dialysis catheter insertion. Coming into the dialysis, oxalate is a very small molecule with a very good dialysis clearance, and the oxalate production per day is around 4.8 millimoles per day, and tissue storage is around 2 to 4 millimoles per day, with dialysate oxalate clearance 2 to 4 millimoles per day in PD and 2 to 4 millimoles per session in a case of hemodialysis. And again, patient, since the oxalate production outnumbers the clearance, patient always at risk of systemic deposition and ensuing systemic oxalosis. So hemodialysis is always better than peritoneal dialysis in terms of oxalate clearance, but whatever the modality of dialysis, either it is going to be hemodialysis or peritoneal dialysis, intensive hemodialysis, or combined hemodialysis or peritoneal dialysis, the sequestration of the oxalate into the tissues is much more, and most of them is going to rebound at the end of a dialysis session. It was 80% of the pre-dialysis levels 24 hours and 95% in 48 hours. So a lot of modalities improving the dialysis has been tried, which are useful in improving the oxalate clearance. You can use the iFlex dialyzer with maximized blood flow rate for better oxalate clearance. And it's always better to have additional sessions per week rather than extended long sessions, because the diffusion gradient gradient will be less, and the removal, if in case of prolonged dialysis, the removal of oxalate from the plasma is relatively low. PD treatment can be intensified by adjusting dwell volume and dwell time according to the PET test. More cycles or exchanges per day are chosen, the more oxalate is removed. So a combination of hemodialysis, beta-dialysis may increase the overall removal of oxalate. Standard HD regimens may not help, so needs intensified HD regimens with high flex dialyzer with high blood flow rate. But HT might restrict the pot of oxalate eliminated via urine and beta-dialysis during the session and the early interdialytic phase. So insensible timing like CCPD at night and hemodialysis in the morning will be much more fruitful. So any form of dialysis should be avoided at the most possible, and you always consider preemptive transplant and consider dialysis only as a temporary therapy. Early start dialysis when the GFR is around 20 to 30 ml may lead to probably decreasing the total body oxalate accumulation, and aim is to achieve the plasma oxalate less than 45 to 50 micromoles per liter. When you do this, it can slow down the intra and extra accumulation of calcium oxalate, and the residual renal function may be preserved longer. Coming to the transplantation for different types of primary hyperoxaluria, type 1, it's always combined liver kidney transplant is the treatment of choice. There is also liver transplant has been tried in as a preemptive measure. Kidney transplant alone is not fruitful, based on earlier studies. Type 2, still kidney transplant alone is better than combined liver kidney, but there are different studies, more studies coming up from recurrence of oxaluria in type 2. They themselves advocate liver transplant because liver is the major target organ for GR-HPR. Benefit of liver transplant is still unclear, but since the bulk of GR-HPR is in the liver, probably a combined liver kidney transplant in type 2 also may be useful. And significant renal disease type 3 is uncommon. So isolated kidney transplant should never be tried, can be tried in resource poor countries when there is no other options available, or in select patients with pyridoxine response patients, which can be seen in 30% of individuals, or with the advent of limesiran, whether it can be useful in the future. Time only will have to see, and logics also comes into play. We don't know how much it's going to cost for limesiran. And preemptive liver transplantation, again, promising reports early on, but remains controversial because whether you have to do a liver transplant at the time of diagnosis or the GFR 60, 40. So, and there is also unpredictability in the course of the disease, and the timing is going to be difficult, and disappointing survival rates has been noted in patient preemptive liver transplant. And liver transplant acts as a gene therapy as well as enzyme replacement therapy, and combined liver transplant is the mode of treatment. Dr. Naresh is going to talk much on this. I'm not going to dwell more. So CLKT choice could be simultaneous and sequential. When the simultaneous you do when GFR is 15 to 30 ml, and there is some residual renal function is there, maybe appropriate low risk patients. Abdominal cavity is large enough to hold both organs with separate donors, 2 different donors for each organ in case of cadaveric transplants. Sequential when you consider in case of CKD stage 5, in case of severe systemic oxalosis, and probably if the donor is going to the same donor is going to donate the liver as well as the kidney, or in case of severe infantile form, less than 2 years of age. So these are one of the earliest experience with primary hyperoxalate published way back in 2015 for the initial 4-5 years. We had both simultaneous as well as a sequential transplant. We also had a recurrence of oxalosis even in patients with combined liver kidney transplant who again had a pre-transplant. And most of these patients had bleeding as a complication. So pre-op management all include intensive hemodialysis, dialysis with the aim to keep the serum oxalate less than 45 to 50, and ejection fraction, always check a cardiac ejection fraction, which should be around 40 to 50%, 40 to 40% to undergo surgery. It can be achieved by vigorous hemodialysis 4 to 6 times a week, and always check ECG for any evidence of heart block. Intra or post-op dialysis protocol, until recently, until a year back, we as a protocol initiate CRRT intraoperatively and continue post-operatively until serum creatinine less than 2 with a good diuresis, and to aim to keep the serum oxalate less than 20 micromoles per liter. Once the serum oxalate touches down to less than 20, we take off the patient from CRRT and switch over to intermittent hemodialysis will be considered if patient requiring long period of dialysis or high serum oxalate after transplant severe systemic oxalosis. But last 1 year, we don't do intra-op or immediate post-op unless indicated, unless the patient, the child has delayed graft function. So after CLKT, plasma oxalate returns normal before urinary oxalate does, and urinary oxalate remains elevated for as long as several years of transplant due to the slow resolubilization of systemic calcium oxalate deposition, and can lead to recurrent nephrocalcinosis or renal calculi and can jeopardize the graft function. So independent of the transplant strategy, I think we always advocate forced fluid intake around 2 to 3 liters per meter squared per day, and use of crystallization inhibitors in the is advocated. So the oxalate goals when the patient is CKD with on conservative management is around 0.4 millimoles per liter. Even after transplantation is again the 0.4 millimeters plasma oxalate. When the patient on dialysis, to prevent systemic oxalosis is less than 45 to 50 micromoles per liter, and after transplant the goal is less than 20 micromoles. It is not always achieved in most of the patients. So this is a representation of one of the patients who had a combined liver kidney, who had a sequential liver kidney transplant. So the one on the left shows plasma oxalate pre-liver transplant, and the immediate post-liver transplant, so again it's high around 60s, and POD1 of kidney transplant, the plasma oxalate dropped down to 29, around 29, and 4 weeks around 8.9, and urinary oxalate at 4 weeks around still high at 90.6 milligram per day. Even after 1 year, you can show that plasma oxalate still at 36, the same patient, the same child, it's around 16-year-old, 36, and the urinary oxalate still high at 170. The patient had probably marginal graft dysfunction because of oxalate, continued hyperoxaluria, creatinine is around 1.6 to 1.5 to 1.6. Now it's third year post-transplant. So to conclude, patients with PH1 and systemic oxalosis represent a difficult management problem. Outcomes may be improved with early and accurate diagnosis followed by aggressive supportive management, aggressive dialysis to prevent oxalate deposition, establish renal failure. And minimization of duration of dialysis will improve both the quality of life and survival of the patients. Correction of the enzyme defect by liver transplantation before systemic oxalosis develops is prudent, and CLKT is the treatment of choice, simultaneous or sequential based on the phenotypic variation in the individual. Thank you. So I just leave the baton with Dr. Naresh.
Thank you very much, Dr. Chandrasekaran, for that wonderful lecture and an overview of the nephrological part, the medical part from the kidney point of view. So now it is up to Dr. Naresh Shanmugam. He is a friend of mine, although we don't speak as much as we would like to because of the distance, but we do interact. And whenever I have got any liver problems or liver transplant issues, I usually call him up. So he is a pediatric hepatologist and gastroenterologist and is director for the Dr. Rela Institute and Medical Center in Chennai. He has completed his training from UK, both in pediatrics as well as in pediatric hepatology and gastro and nutrition, and is also an examiner for the Royal College of Pediatrics and Child Health, where we bump into each other quite often. So, Dr. Naresh, it is up to you now to tell us about this primary hyperoxaluria from a hepatology point of view.
Thanks, Rajiv. Thanks, Rajiv, for the nice introduction. So Rajiv and myself interact frequently, and we meet only during the exam times. And he's a nice, charming person. And first, I would like to thank Dr. Kalaivani and Dr. Namalwar for inviting me. I think I am the only odd man out here, I think, speaking to nephrologists. VC told me yesterday to cut short my timing so that he can give a bit more talk. So I tried to limit my slides. And even with it, I think some of the slides might be a bit overlapping, but I'll try to put it in slightly a different way so that you can understand. So what is the role of a hepatologist in dealing with primary hyperoxaluria? The answer is quite simple. Just we need to follow the instructions of the nephrologist. And that's what we do. We see, I'm just joking. No, we usually work as a team. So we need to form a strong team to do a combined liver kidney transplant because it's a quite complicated procedure. And we do have certain issues with the liver, and the nephrologist has some issues with kidneys. So we need to put things together to make it work and to make this thing as a successful transplant. So we need to work up a team. So most important role of the hepatologist is to be a part of a team and work together. So let me start with the indications for a combined liver kidney. Though it's a bit out of the syllabus, just for completion's sake, I'm just highlighting. There are not many indications in children. First one is primary hyperoxaluria. Then we have metabolic condition like methylmalonic acidemia, atypical hemolytic uremic syndrome, and developmental anomalies like congenital hepatic fibrosis with ARPKD. So most common would be, I think, in our practice, we do for primary hyperoxaluria and ARPKD. So pathogenesis, Dr. VC has gone through, I think, quite in detail. So what happens with this problem? The oxalate forms and the kidney tries to excrete, and the kidney tries harder to excrete. And at one point, the kidney gets clogged. Until that time, the oxalate circulates freely in the blood, not much of deposit in the bone. But once the kidney goes down, when the kidney clogs up and there is a renal failure, then there is a rapid deterioration, rapid accumulation of this oxalate in bones, blood vessels, muscles, and heart. So this patient, sometimes parents think doing a combined kidney liver transplantation for a kidney problem is too much. But coming to quality of life, even though you do dialysis, you get bone pain, you have problem with blood pressure because the blood vessels become so thick or they are resistant to vasopressors because of the oxalate deposits. And you have cardiac anomalies, ejection fraction goes down. So at some point, they need to go for a combined kidney liver transplantation, as we know that doing a kidney transplant alone will not be beneficial. So when do we time the transplantation? As I said, isolated renal transplant, isolated liver transplant, combined, which can be a simultaneous or sequential. Isolated kidney transplant is not advocated as the kidney will go off quite soon, apart from selective pyridoxine responsive patients. Sometimes we do a preemptive isolated liver transplant. I think usually one of the sibling will have a combined kidney liver, and while screening we find out that the other sibling has the problem as well. And when I think the problem here is we cannot assess the time frame for actual when the kidneys are going to go off or when the problem is going to happen. So we monitor them. When the GFR touches around 45 to 50, then we can safely do a preemptive liver transplant, which we have done. And a combined kidney liver, which could be either simultaneous or a sequential. So coming to simultaneous, which is in same sitting, we do a liver and kidney transplant. In cadaver setting, it has an advantage that if the liver comes from the same donor as of the kidneys, the rejection rates are low. So it has an advantage in cadaver renal transplant setting, but in live-related setting, when both the organs come from two different people, it doesn't make sense when we have a simultaneous liver kidney. And also, always there is a worry that if we do a simultaneous liver kidney transplant, the body will mobilize all the oxalate from the bones and muscles and clog the kidney and damage the kidney. Then comes a sequential liver transplant. In our setting where the live related, if for a child, if the same donor is going to give both the kidneys and liver, we can do a sequential kidney liver transplant. Or when the GFR is very low and we are worried that the kidney could be damaged due to the mobilization of tissue oxalate, we can do a sequential. If we harvest the organ from the same donor, both the liver and the kidney, we usually wait for a 6 weeks time in between. Coming to getting a donor in live transplant, I think obviously the parents would be the first choice, and usually the parents would come forward for the transplant. And if it's uncle or aunt, we definitely need to have a genetic diagnosis because they can be homozygous. Coming to parents, very unlikely to be a homozygous, but definitely they are heterozygous. And this is a condition where in a heterozygous state, the urine oxalate can be high. So when we usually do a 24-hour urine check for the donor, and if it is elevated, he can do a liver donation because the amount of liver we would take would be 20%, 30%. And it's not the enzyme what we are worried about here. Here we are worried about kidney donation. If the donor has high urinary oxalate, we wouldn't choose them as a kidney donor, even if they are heterozygous, because long term, we wouldn't know what would happen with the single kidney for the donor. So for a donor, heterozygous donor with high urine oxalate, donation is contraindicated. And if the urine oxalate is fine, I think they can donate. So what do we do pre-operative? As Dr. VC said, intensive hemodialysis we can do. If they are on peritoneal dialysis, we can put them on continuous ambulatory peritoneal dialysis. The problem here is, as he said, why not we can't put them on a continuous dialysis like CRRT or something? The problem is all the oxalate sits in the bone. And when we remove the oxalate from the blood using dialysis, the homeostasis, that is the equilibrium that maintains between the bone oxalate and the serum oxalate, takes some time for mobilization. So within 4 or 5 hours, the plasma oxalate might come down to a very low level. And over the next 1 day or 2 days, the bone oxalate mobilizes to the blood, and then we do the dialysis, and that's why it works better. So we put on a plan that we do an aggressive dialysis, but also we have to think that we have to give a break in between so that there is a mobilization of oxalate from the bones to the blood. Otherwise, just doing dialysis 7 days a week will not be of much help. And obviously, cardiac status is one thing which we look, because it essentially makes somebody a contraindication for a transplant. Minimum, the ejection fraction should be at least 40%. And you can see many of the patients came with the ejection fraction, low ejection fraction, and we need to put them on intensive dialysis regimen so that it increases, and then we take them for a transplant. You can see at 3 months of dialysis, how with the intense dialysis, how it has improved. Blood pressure in hyperoxaluria is a difficult thing to control. As I said, because of the oxalate deposits in the vessels, blood vessels, the response to vasopressors, even when they have issues with hypotension, when we are trying to give adrenaline, noradrenaline, the response is quite erratic. So it can either shoot up too high, too low, and and even bleeding is quite high because of the same issue. And also the oxalate, for some reason, decreases the binding capacity of the platelets. So they are more coagulant, and we have more of bleeding issues. And the dialysis before surgery, usually we finish off the dialysis 4 to 6 hours before the transplant, so that the rebound is not there. So the transplant is done before the rebound happens, so that when we put the kidney in, the kidney is not sort of loaded with oxalate. So introp, I think Dr. BC has said, CRRT, the creatinine is more than 2, and we make sure that there is a good urine output. Post-transplant, it's a standard protocol we do for immunosuppression, start them on tacrolimus, CellCept. Usually for children, we don't start on CellCept, but if they have kidney transplant combined, we start them on CellCept as well. And every 8 hours, we do the blood test, and we decrease it, the frequency day by day. By 5th day, it will be once daily bloods. And we also check the serum oxalate levels, so that if it's quite high, we might sort of put them on dialysis. Okay, coming to the fluid balance. For a liver transplant, we don't want the CVP to be high. More than 10 CVP can cause congestion of the liver graft and can cause liver failure. So the CVP has to be less than 10. But for the kidney, you need more fluids to flush it. So it is a bit of a balance we need to maintain to make sure that the CVP doesn't go too high, otherwise the liver gets damaged, and the fluid has to be adequate so that the kidney flow is there. And usually we calculate, this is how we calculate the urine output plus wound and drain. Usually with the abdominal drain, they get lost, and you have insensible loss. And we try to give this, try to replace it on hourly basis, because sometimes even within 1 hour time, they might dialysis 200 ml. So every hour, so usually couple of nurses, we put them on standby. So managing the fluid on day 1 is very crucial. Usually we replace the urine output with the 0.45 saline, and the drain usually we replace with 5% albumin, because the ascitic fluid is rich in albumin. And then I think all these things are covered by Dr. VC. So it's always better to overhydrate them than underhydrate, because it's always a problem. When you have a doubt, it's better to be on the hydration side. As I said, most of the children are polyuric post-transplant. So we have to have sort of discussion with the nephrologist, like every 3 hours, 4 hours, we call them and discuss the fluid balance. So VC knows, like we call them personally, and the nurses, he gives instruction directly to the nurses. We have a quite tight control on fluid balance, because suddenly they can go negative, and even negative dehydration can cause vascular thrombosis. So we have to be quite careful with the diuretic part as well. And with the hyperoxaluria, we aim 6 ml per kg urine output, and if the urine flow is less than 3 ml per kg, we put them on furosemide infusion. And immunosuppression is standard. But usually for liver transplant, we don't do induction with besiliximab, but if there's a combined kidney liver, we do with besiliximab, and we start them on mycophenolate. And I think, as Dr. VC has shown, these are the dots of urine oxalate and over a period of time. So you can see it takes nearly 3 years to 4 years for the oxalate in the body to remove the oxalate. And these children will have quite a brittle bones, and they are quite easy to fracture. And during post-transplant period, you get fractures, particularly when they are trying to put cannulas, you get hand fracture of the hand, or sometimes they can have vertebral fractures because of this, due to this. And you can see this is from one of the patient who had nephrocalcinosis after transplant. You can see the refractive crystal inside the kidney. And I think with this, I will close my talk. Thank you all for listening. And most of the things what I have said and the charts which we have shown comes from this textbook which I have published, and Dr. VC has authored the chapter on combined kidney liver transplant in this. So thank you very much.
Thank you very much, Naresh. An excellent talk and quite practical. I found it quite useful. And I'm a bit naive in combined liver kidney transplantation. We're working in centers in UK which were not doing liver. So I'm always eager to know more of it. So we move on to the next part of the session, where we have Dr. Karthik Mathivanan, who will be telling us more on the surgical aspect of this combined liver kidney transplantation. Dr. Mathivanan is the head and clinical lead for Chittenden Institute of Liver Science. He did his fellowship in liver and multi-organ transplant from Medanta and Apollo. He is the recipient of multiple grants, and his special area of transplant interest includes geriatrics, ABO incompatible, transplant oncology, and the various organ preservation techniques. So we are eager to hear about the surgical aspect of it. So it is over to you, Dr. Mathivanan.
Dr. Karthik, you are not heard.
Yeah.
Dr. Karthik, now you're audible.
Yeah.
Yes.
At the outset, I would like to thank Dr. Kalaivani and Dr. Nammalwar for giving me this opportunity to talk about primary oxaluria, the role of liver transplant surgeons in this forum. And actually, the role of liver transplant surgeon is actually minuscule because already hepatologist and nephrologist have briefed enough. And we'll quickly go on to the topic. So the key issues which you're going to address is about what are the timing of the transplant? When do we transplant a patient with hyperoxaluria? And what are the types of transplant? And in an Indian scenario, it's predominantly a living donor liver transplant program due to scarcity of deceased donors. And donor consideration when it comes to the choice of the donor, because it's a genetic disorder, and usually siblings or the parents come forward to donate an organ. And post-operatively, how do you manage these patients after a combined liver kidney transplant in hyperoxaluria setting? And what are the long-term outcomes of transplants? And what are the new strategies in the current era? So when do we actually plan for a liver transplant or a kidney transplant, or be it any transplant for hyperoxaluria? Surgeons do play a vital role, although it's a minuscule, along with the physicians, especially the hepatologist and the nephrologist. It is technically challenging for the entire team, given the phenotypic variability and the heterogeneity of the genes involved in it. For example, even though the patient has got a chronic end-stage kidney disease, the amount of oxalosis in the body might be less. And vice versa, a patient having a moderate amount of kidney dysfunction, but have an abnormal oxalosis amount in the body. And the type of pH also determines the type of transplant which needs to be carried out. There are 3 types of primary hyperoxaluria. Type 1, which is very common. Type 2 and type 3 is less common. Type 1 usually needs either a liver and a liver kidney transplant, and type 2 it needs only a kidney transplant, and type 3 need not have any kidney transplant, any transplant at all. Usually when the GFR falls below 15 to 30 ml per minute, then a transplant is planned. When you look at the evolution of treatment options in primary hyperoxaluria, initially we tried the conservative or a dialysis treatment was only available. The first renal transplant was done in 1969 and followed by a combined liver kidney transplant in 1985. And later, 1989, liver transplant alone was attempted. And what are the things to be considered before transplant? As a transplant surgeon, we look at the age of the patient, whether it's an infant or a pediatric patient or an adult patient, because the transplant of either a liver kidney or a simultaneous kidney transplant needs to be considered depending upon the age of the patient and the abdominal domain. Suppose it's an infant, putting in a liver as well as a kidney can be difficult at times. So we need to plan the transplant, first the liver and second kidney transplant. It's called the sequential liver kidney transplant. And depending upon the CKD stage, and also the systemic oxalic load, which plays a vital role in choosing the method of transplant. And genetic mutation analysis also plays a vital role in choosing the type of transplant. And the various transplant options are a preemptive liver transplant, a sequential liver kidney transplant, or a combined liver kidney transplant, or a kidney transplant alone. So suggested transplant options is better represented in this slide. If there is a stage 3 CKD, then isolated kidney transplant, isolated liver transplant, the preemptive liver transplant can be attempted. But however, it has to be done judiciously and not applied in all subset of population. In a CKD stage 4 patient, the simultaneous liver kidney is a good option. And the CKD 5 stage patient, both simultaneous or a sequential liver kidney can be attempted. And if it's an infantile, less than 2 years, either a simultaneous liver kidney or a sequential liver kidney, depending upon the abdominal domain of the patient. And the preemptive liver transplant, what is the rationale and recommended population, advantages and outcomes, which we're going to discuss right now. The rationale of a preemptive liver transplant is it's got a very limited role in a small subset of population. Usually it is considered as an effective functional gene therapy. For example, the subset of population is usually the siblings of previously affected end stage or previously affected renal or liver failure patients. In the progressive renal disease, with a GFR of 40 to 60 ml per minute or 1.73 meters square, you consider preemptive liver transplant. So how do you gauge the progressive renal disease in a moderate functioning kidneys? Any deterioration in the GFR more than 20 ml within 2 years of diagnosis is considered as a progressive renal disease. An early preemptive transplantation should be considered in CKD stage 3 patients. The word preemptive liver transplant may sound scary, but however, even the technical advancement in liver transplant in the last decade and the superior immunosuppressive protocols, the mortality is only less than 5%. The long-term effect of immunosuppressant has to be weighed with the risk-benefit ratio of transplant and non-transplant. It stabilizes the long-term renal function and even reversal of nephrocalcinosis has been established. This graph shows the renal function stabilization in a preemptive liver transplant patient. And evidence has been shown that nephrocalcinosis has been halted. And sequential liver kidney transplant, we're going to discuss about the rationale, the recommended population, advantages, and the outcomes. In a sequential liver kidney transplant, choosing between a combined and a sequential liver kidney transplant always remains a controversial thing. So choosing the right population has led to a success in a sequential liver kidney transplant. Usually it is performed in small children where the abdominal domain is not enough to hold a liver as well as a kidney. And the subset of population here who benefit from sequential liver kidney transplant are patients with long-term renal replacement therapy with high systemic oxalosis load. Because once after doing a liver transplant, it takes care of the further load of systemic oxalosis. Usually it takes years for the body to clear the already existing high load of oxalosis. However, intensified dialysis protocol to create a better kidney graft survival condition before kidney transplant is established in a sequential liver kidney transplant. And the darker side of a sequential liver kidney transplant is the need for continued dialysis increases the risk of hemorrhage. And bleeding has been reported in many cases in sequential liver kidney transplant. And the risk from sepsis, that is bacterial and fungal infection, mortality has been reported. But however, this mortality should be compared with a combined procedure. And the advantages of a sequential liver kidney transplant is, in few cases, the native renal function may improve after liver transplant. So thereby it alleviates the need for an additional kidney transplant later. It also prevents the renal injury, which happens during a combined liver kidney transplant procedure. Systemic oxalosis, like I said, it takes months to clear. And during the process, the kidney graft might take a hit and it can lead to a kidney failure if the systemic oxalosis load is quite high. The simultaneously transplanted kidney is still at a risk despite the timing. And considering the donor safety profile, usually in our country, it's predominantly a living donor liver transplant program or a kidney transplant program. And the availability of even the living donor, people coming forward to donate, is very scarce. And especially in this kind of a genetic issue, the siblings usually are homozygous and they're not qualified for a donation. With the single donor, subjecting them for both the combined kidney and the liver donation puts the donor's life at a risk. So this sequential liver kidney transplant gives some time for the liver to regenerate, and so that when they come back for another donation, the profile is considered much safer than in a single sitting. And combined liver kidney transplant is still the mainstream transplant strategy for most of the patients. It solves both the hepatic enzyme disorder as well as the renal dysfunction. And there have been encouraging long-term results in pediatric patients. CLKT suits patients with short dialysis period or without systemic oxalosis. If a patient has got a severe systemic oxalosis load, then we prefer a sequential transplant than a combined liver kidney transplant to safeguard the kidney graft. The advantages and challenges in a combined liver kidney transplant are, one, the advantage, it can be immunoprotective if taken from a single donor. The donor availability and the risk involved in the live donors can be challenging at times in doing it from a single donor. And smaller children can be limiting factors given the narrow abdominal cavity. The mortality and morbidity are still high when compared to a sequential procedure. But however, in the last decade, the improvement in the surgical techniques has decreased the mortality rate, but still the morbidity rate is being quite challenging for patients or for surgeons and the hepatologists in the post-operative period. The donor strategies which are used in our country are mostly it's living donor liver transplant or a kidney transplant program. And there is an abundant shortage of the deceased donor. So we completely rely on a living donor, which is a feasible option. And the specific challenges in choosing a family donor is given the nature of the genetic heterogeneity of the problem. But however, heterozygous parents, who are the carriers, can safely donate, and it has not been contraindicated so far. Siblings, 25% express homozygosity, and it is considered as a contraindication. Genetic testing is mandatory for siblings if we don't have any other donors before we subject them for a donation. And the living donor options can either be from the same kidney, from the same person. The liver and kidney may be harvested simultaneously from the same donor, or two separate donors can be used, or sequentially from the same donor in different time periods. Usually about 6 months is the median interval time in various studies reported. Some centers do even in a gap of 6 to 8 weeks. And separate donors, you need two donors if the donors are available. And post-operative supportive measures which we need to take care is the high fluid intake, about more than 2 to 3 liters per meter square per day. And citrate and thiazide diuretics needs to be added to reduce the supersaturation of calcium oxalate. And always pay attention to reduced urine output and hypovolemia, which needs to be addressed immediately in the immediate post-operative period. And post-transplant dialysis, however, it was used more frequently previously, but nowadays it's limited only to the delayed graft function and those patients with high systemic oxalate load. And dietary restrictions also help in containing the oxalate load in these patients. And how do you do the surveillance of measuring the plasma or the urine oxalate levels to keep it at check? And how do you monitor the post-transplant treatment? Serum oxalate levels, however, are not reliable given the rapidity in fall after a liver transplant. Serial measurements of urinary oxalates and crystaluria guide post-transplant prophylaxis in taking measurements either in need of dialysis or to increase the fluid intake. 24 hours urine oxalate creatinine ratio has also been useful. But recently, quantitative analysis of crystaluria with oxalate crystals volume measurement in fresh urine can be performed in hours, and which will be able to guide the treatment or prophylaxis which needs to be taken immediately. Standardized technique to quantify crystaluria available in a very few centers. When you compare the survival rates of, this is one particular study which released recently, which shows the long-term survival effects. When you compare the long-term survival effect of 1 year, 5 year, and 10 year of patient survival in combined liver kidney and sequential liver kidney transplant, the 1 year survival rate is about 89% in CLKT population and about 100% in sequential liver kidney transplantation. The 5 years about 77 and 84%, and 10 years about 67 and 84%. But however, different level of pre-transplant conditions and longer pre-transplant duration has led to superior results in a sequential liver kidney transplant. The liver graft survival, if you take about 5 years liver graft survivals, it's almost the same in both combined or a sequential liver kidney transplant. The kidney graft function in about the 5 year kidney graft function is about 78%, and in the sequential liver kidney transplant, it's about 85%. So clearly, there's an advantage has been shown in this study in the sequential liver transplant, sequential liver kidney transplant. But however, what we have to look here is the pre-transplant renal condition and the longer pre-transplant duration of patient dialysis. And the Kaplan-Meier curve in both these patients, here is a comparison of it. And when you look at the live donor, this is not, it's about combined liver kidney transplant in adults with primary hyperoxaluria. From data from 2000 to 2017. However, the results have been tremendously, quite well in the last decade. And this is the largest series which has been published so far with 220 transplants. But here it is a mixture of both the deceased donor and the living donor. And when you look at the living donor data, it's purely about it's only one in the last decade. We have got a total of 25 patients with living donor for combined liver kidney patients. And most of them are about simultaneous liver kidney transplant has been done. And this is one study from Indian study which has been done from one of the centers in South India. It's the largest study which has been published in India so far. It's about 7 patients, of which most of them are simultaneous liver kidney patients. And a couple of them are about sequential liver kidney transplantation, and which, Dr. Naresh and Dr. Chandrasekaran did talk about the study. And this is from my own center. The data is yet to be published. So we have done about, my previous center in Medanta, about started from 2007 till 2019, we've done so far 10 liver transplants for primary hyperoxaluria, of which 4 of them are pediatric population, and 3 of them from combined liver with a single donor. And 1 was a cadaveric donor, and there is 100% success rate in about pediatric population. And however, in adults, the 6 patients, 3 has been, we lost 3 patients, so 50% mortality is quite high. The data is yet to be published. And the new strategies in the era of promising therapeutic perspectives, when you see the RNA interference drug, so which is promising in management of primary oxaluria, at length. So lumasiran is a lumasiran is a drug which targets the hepatic glyoxylate, which is the phase 3 is completed and recently it has got an FDA approval as well. And who will still need a kidney transplant in the era of lumasiran is what we're looking at. And the patients who are already been in end-stage kidney disease will definitely need a kidney transplant in the future. And the preemptive or an early kidney transplant is can be advocated in the era of lumasiran. And this is a new treatment strategy in the era of promising therapeutic. Is this clear or not? we're able to see the slide. I mean, it's kind of.
Yeah, we're able to see, but it is not in a readable format.
Format, no? Yeah. I'm sorry for the slide.
That's fine.
So what we intend to say here is, this is only a proposed protocol which has been devised and recently published with the help of lumisiran. And any patients who have been early diagnosed with primary hyperoxaluria with an eGFR more than 30, the RNAi has been promising, and which can be followed up with the further kidney function. Any patients with the eGFR of less than 30 ml, and you try RNA interface duct, and look at the high systemic storage. If it is still high, then you delay the transplant and put them back on RNA and continue the therapy. If the systemic storage is less, then you advocate early kidney transplantation and consider dialysis or other conservative measures till the normalization of urinary oxalate happens. And chronic dialysis patients can be also put on the RNA interference drugs, that is lumisiran, and followed by hemodialysis to achieve a target of plasma oxalate of less than 20 micromoles. And if it has been achieved, then kidney transplant can be safely done alone, and consider hemodialysis as conservative measures till the normalization of urinary oxalate. This is still an hypothesis or it has been proposed. We have to wait for the results to be seen. With this, I would like to conclude my study, my talk.
Rajiv Sinha, sir, you're there?
Yes, I'm there. So thank you very much, Dr. Karthik. And so next is my talk, is it?
Yeah, sir. The next talk is by Dr. Rajiv Sinha. He's going to talk on renal stone disease in children. Over to you, sir.
Okay, so I hope I'm audible. And after those excellent talk on primary hyperoxaluria, what we will do is that in the next 25-30 minutes, we will try to give an overview of the renal stone disease in children. The motto of pediatric stone management is leave no stone unturned. And then this is what we will be discussing over the next slides. That we have to find out, or we should be trying our best to find out the cause of the underlying etiology. These words are sometimes used interchangeably: nephrocalcinosis, nephrolithiasis, and urolithiasis. Basically, nephrocalcinosis, as we know, is a deposition of the calcium within the kidney tissues, and either in the medulla or in the cortex. Nephrocalcinosis can go on to develop nephrolithiasis. But it's not that nephrocalcinosis is equal to nephrolithiasis. Nephrolithiasis is that when you have got stone in the kidney, and urolithiasis is a more of an umbrella term where you have a stone in the collecting system. But the term nephrolithiasis and urolithiasis is often interchangeably used. So the take-home message is that nephrocalcinosis can go on to develop a nephrolithiasis, and you can have coexisting nephrocalcinosis with nephrolithiasis. Kidney stone is as old as mankind, and even in our early scriptures, like Sushruta, etc., there are mention of kidney stones and bladder stones. Epidemiology-wise, obviously it is more common in adult and less in children. Male are more commonly affected, although in children you lose the male preponderance slightly. Children differ from adult in the sense that they have a higher history of positive of someone in the family having stones. They have got more than 50% chances of underlying metabolic etiology, and because they live longer, they are likely to have more risk of CKD if not treated appropriately. Last decade or couple of decades, it has been seen that the incidence of nephrolithiasis in children is rising. This particular study is from North Carolina, And what it shows is that even when they adjusted for hospital admission rate, there was a steady rise in the incidence of pediatric nephrolithiasis, more commonly seen among the white population there, and more commonly seen among the adolescents. And it is felt that there is an increase of 6 to 10% annually in the incidence of nephrolithiasis in pediatric. This is a study more close home from Sindh Institute of Urology, and what is quite amazing here is that more than 50% of the workload in pediatric urology is related to nephrolithiasis or urolithiasis. Kidney stone is something that which is not demarcated by economic barriers. So be it poor, be it rich, you can have it, although the underlying etiology might differ. And we all know about this stone belt, somewhat around the tropicals, but not always. In their lifetime, it is said that about 2 to 5% of the Asian population and 8 to 15% of North American and Europeans will form stones. Number of factors contribute, and it is not all genetics. Genetic does play a role, degree of consanguinity plays a role, but also like local prevalence of other diseases. For example, in Thailand, you have got a higher incidence of schistosomiasis, and they have got a high incidence of bladder stone. Similarly, like it has been found in studies that among North Indian population, you have an higher incidence of lower oxalobacter, and that might predispose to the stones. Environment plays a very important role and explains to a lot why it is quite common among Bedouins. In desert regions, also it is quite common in the arid regions of North India. But it is also the diet and water intake. So poor water intakes, if the water is not available, or diet like a high salt intake in developed industrialized countries can all predispose to kidney stone and can explain the rising incidence. Apart from that, we have got the urinary tract malformations, incidence of recurrent UTIs. It is quite common nephrocalcinosis as well as nephrolithiasis in preterm, low birth weight babies and those who we call NICU graduates. Use of diuretics, anticonvulsants, antibiotics, even simple antibiotics like ceftriaxone has been shown to predispose to stones. Underlying chronic bowel disease, neurological disease, they are often immobilized, so they are less mobile, and that can cause stone. But also, like if you are starting them on ketogenic diet, if you are on topiramate, all of them predisposes to stone, and as does fractures. Type of stones, we can classify it as staghorn or non-staghorn. Staghorn stones are the one where the stone is extending into the various calyces as well as the pelvis, whereas non-staghorn stone are relegated to one area. So you can have a calyceal stone, you can have a pelvic stone, ureteric stones, or bladder stones. Also, you can classify a stone based on composition, and the commonest of that, as we all know, is the calcium oxalate, and then we have the calcium phosphate and the uric acid stones. But in developing countries with high incidence of urine infections, you can have a high incidence of struvite stones. These are the various crystals that you can look into the urine. And I'm not going to the details of them. So let us now spend some time on pathophysiology. Just like life, here also it is a balance between the good and the evil. So on the one side you have promoters of stone like high urine calcium, oxalate, uric acid, cysteine, certain drugs. We spoke about ceftriaxone, but more commonly known are drugs like acyclovir, and then infections. On the other hand, we have got angels to save us, the inhibitors like citrate, magnesium, pyrophosphate, and very importantly, high urine volume. And again, similar to live. Hello? Hello, can you hear? Hello?
You can hear,
Hello,
sir.
can you hear me?
Yeah, we are
but
hearing
something
you.
something has come up. Your presentation, something has come up. Your presentation is scheduled to end in 5 minutes, and I lost the slides.
Oh, yeah, I am also getting that. You can add 30 minutes. You can go ahead. You can go ahead.
So, but how do so I go back to the slides? Okay.
No, you have the Windows. Add 30 minutes. You just click that.
Add 30 minutes in the layout.
No. When it end up in 5 minutes, you got that pop up, no?
Yeah, but I can't see where I can add it.
You go to your. You're not able to see now.
I can see that your presentation.
We are able to see your slide.
We are able to see your slides,
Okay.
sir.
Is it moving now, right? Okay.
It's moving, sir.
So, okay. So, sorry about that. So, next we were talking about, we talked about the good things, the bad things, and then like in life, we have got certain factors which we don't know whether it is bad or good. Like urine pH, sometimes it is good. For example, in cystinuria, and sometimes it is bad. For example, it can like a high urine pH can further precipitate calcium phosphate, whereas the high urine pH on the other hand is good for cystinuria. And ultimately, stone happens if there is a loss of balance in the yin and the yang. So, in nutshell, stone will happen if the solutes exceed in concentration relative to their solubility. Stone will happen if there is a crystallization happens due to an imbalance between the presence of promoters and inhibitors, and this gets attached to crystals in the nephroliths, which are usually because of epithelial abnormalities. Keeping it very simple, from this Lancet article, there are 3 factors predisposing: genetic, dietary, and acquired metabolic factors, and an interaction in these 3 results in stone. Quickly, we will go through the etiologies. We have covered the factors behind the etiologies. So we know that if there is an increased solute, we will have stone. So and that will be if we are having with hypercalciuria, hyperoxaluria, hyperuricasuria, cystinuria. If there is a decrease in the inhibitors, that is citrates goes down in the urine, or hypomagnesemia, hypercitraturia can happen normal, can happen by itself, or it can be quite commonly seen in renal tubular acidosis. Hypomagnesemia is another region where you can have stone formation. Neurological conditions like any obstruction resulting into stasis, infections commonly with Proteus, Klebsiella, Pseudomonas, all of that results into an alkaline urine, and ultimately you have got magnesium ammonium phosphate stones. And lastly, we have also discussed this in a bit, environmental factors. We did discuss about the stone belt. We did discuss about dehydrations, and we also mentioned about certain drugs. We mentioned about ceftriaxone, acyclovir, topiramate, etc. Now, how do children present with stones? This is something again which is quite different from adult. And as shown in this particular study, the presentation depends upon which age they are presenting. For example, in an infant, you are more likely they are more likely to present with either urinary tract infections or often incidentally discovered. Hematuria is common in both 1 to 5 years and more than 5 years, but the classical presentation of flank pain or restlessness is more common in children above 5 years. In fact, for very small children, infants and around infancy, it is very difficult often to diagnose stone, and there are reports of infants just touching their genitalia, and that may be an indication that there are some stones there. Evaluation, like always, a thorough history is very, very important, and family history is very important. You have to go back to at least 2 or 3 generations to find out about stones. In history of immobilization, some proper clinical findings of hematuria, UTI, in history of a passage of stones. Imaging we will deal later, and we will also deal later in details about the metabolic workup of both the urine and blood serum. So, and the last point is important, that if you get the stone, you should always try to get the stone. Often it is not possible, but if you get the stone, you should subject it to infrared spectroscopy or X-ray diffractions. So this is about the imaging. One line summarizes it all. Ultrasound is the best modality at the moment in pediatric. Definitely, ultrasound has got a low sensitivity when compared to CT scan. One of the studies said that it has a 70% sensitivity and 62% negative predictive value. But that study itself showed that the stones that are missed by ultrasound are usually small. Ultrasound, I admit, is operator dependent, and hence it should be done by someone who is quite used to doing a pediatric urological related ultrasound scan, and they can use surrogate markers such as a ureteric dilatation, twinkling artifact on Doppler studies to sort of suspect stones, and then if your suspicion degree is high and still you are not finding a stone, then you can go forward for a CT. CT ideally should be a low radiation dose CT. Abdominal X-ray is cheap but has got low sensitivity, and although as I said that calcium oxalate stone and calcium phosphate are the common and they are radiopaque, but if your abdomen and gut is not prepared, then you may lose the stone among all your poos and your gases. Now, do we really need a comprehensive stone workup? Going back to the motto of this talk, that leaving no stone unturned. This study was from Great Ormond Street Hospital. It is often quoted in when they looked at 124 children, and they showed that nearly 50% of them had a metabolic cause, and the commonest was hypercalciuria followed by cystinuria. Closer home from AIMS, they also showed in a smaller cohort of 32 children that 44% of the time they were able to find a metabolic cause. And again, hypercalciuria was commonest. This is a very important study. Why? Because it shows, it gives us 2 messages. One is that, so basically what they did was that they looked after stone treatment for any residual stone fragmentation. And they found that even small residual stone fragmentations are important. These children have increased chances of further significant stone problem. And this increases if you are having a metabolic problem, underlying metabolic etiology. So basically this slide gives you 2 messages. One is that even small residual fragments requires regular follow-up. Secondly is that identifying metabolic etiology will prevent the small problem to become big problem in future. So, sorry, I'm repeating myself, but this is an important take-home message for pediatricians and for the surgeons and the urologists who get involved in this. That clinicians should understand that nephrolithiasis can be a mere sentinel of an underlying disorder, and they should exercise vigilance to unveil that disease. So this is what we mean by stone workup. Sorry if you can't see it properly, but basically stone workup means a comprehensive urine and blood workup. Urine workup, I'll first say about the blood. Blood will be a usual routine renal profile, sodium, potassium, urea, creatine, calcium, phosphate, all those things. Plus, always do a magnesium because often it is important, and we have also seen that magnesium can have some effect on stones. Also, low magnesium can give some indication of some causes of nephrocalcinosis. Always do check for bicarbonate because that will help us with renal tubular acidosis if there is anything like underlying or even Bartus in nephrocalcinosis. For urine, you could do a comprehensive workup of 20, and preferably it is 24 hours, although in fact you can go for a spot urine ratios. And what we look at is, apart from protein, creatinine, we look at oxalate, citrate, phosphate, calcium, and uric acid, and also look for cysteine. And urine microscopy is important because that will show the crystals, particularly like, for example, cystinuria is diagnostic. Like if you see cystine crystals, it is quite diagnostic of cystinuria. And also if you see this characteristic 2,8-hydroxyadenine crystals, then you have a diagnosis there. Remember that just don't go by the lab value. Make sure that they have reference as per the age. Lastly, we will go to the management part. Your pain management is very important. It can be very, very painful, and often just oral analgesic may not be sufficient. Desmopressin can be used if it is analgesic resistant or contraindicated. Analgesia is contraindicated, but then I personally don't have much experience in it. Antiemetics, they often vomit, so you should be giving them antiemetic in the acute stages. Intravenous fluid, to give lot of fluid, idea is that you flush out the stone, but the caveat is that this can further aggravate the pain. Antibiotic is a must for associated urosepsis, and most of the guideline says that when you are breaking up a stone or when you are taking out a stone, then also antibiotics should be given, because this stone might have bacteria in the nidus. Urinary alkalizer, we have already discussed that sometimes it is good, sometimes it is bad, and hence you should be knowing ideally what you are dealing with. How about medical expulsive therapy? Luckily, ureter have got calcium channels and alpha channels, alpha 1, alpha 2 channels. So the calcium channel blockers and alpha blockers can be useful. And we have got now meta-analysis showing it is useful, and it has come up as a guideline by the American Urology Association that ureteric stones 10 millimeter or below, your first try should be a medical expulsive therapy. Now, this I often say is medication, and that's how I try to convince my family that maybe I'm not giving that much medication, but diet and fluid are medication. We have got now strong evidence that increased fluid helps, low salt helps, increased fruits help by increasing potassium, and reduction in meat intake also helps. All this will result into less like lower amount of stone. And avoiding oxalate-rich diets and sugary drinks are also useful. But a very important point that dietary modification will only be successful if it is followed by the entire family, and if it is just restricted to the child, it will never be successful. How about calcium restriction? This is often done, often followed, but studies have shown that calcium restriction is not useful, and in fact, it can sometimes aggravate the stone load. I'll not go through this in details, but basically various substances that can be used as a prophylaxis of urinary stones. We have mentioned the citrates, alkalinization, allopurinol, in hyperuricisuria, but remember high dose of allopurinol can precipitate xanthinuria. We do use a thiazide quite a lot among hypercalciuria, but if you're using it on a prolonged period, make sure that you are looking into the lipid metabolism, glucose metabolism, and the uric acids. Surgical management, I'll not go into details because I'm not an expert in it, but when should we be thinking of taking the stone out surgically or subjecting it to ESWL? Mainly once the medical part has failed after 3 to 4 weeks, or in presence of large stones, or, which is very important, single kidney obstructed with stones, or both kidney obstructed with stone, rising creatinine. All these are indications that we need to do something about stones. In an obstructed system with infection, don't immediately go for any interventions, not even ESWL. Ideal is that that you should go for a drainage and antibiotic and then deal with the stone. Kidney stone less than 5 millimeter in diameter have a high chance of being passed off by itself. 5 to 7 millimeter have a 50% chance, and those over 7 millimeter usually require some sort of interventions. This is the schema more or less agreed by the American Urology Association. And Staghorn stone in the pelvis requires percutaneous nephrolithotomy. Stone less than 15 millimeter in pelvis, first you can try ESWL. Stone more than 15 millimeter, you will try some sort of an endoscopic retrieval nowadays. Lower pool calyx, they advise again endoscopic retrieval. And ureteric, if it is high up and it is approachable to the ESWL, then approachable by the ESWL shock wave, then you go for the ESWL, otherwise endoscopic. And it was already mentioned before that the oxalate stone as well as brucite stones are quite difficult for ESWL. So lastly, I'll now go through some case snippets quickly. This was a 5-year female, intermittent pain abdomen, USG showed mild hydronephroureterosis. Urinary showed pus cell 10 to 12, RBC 30 to 50, but culture was negative, and we did a CT scan. So highlight is that we did not get any stone in the ultrasound, but still we did a CT scan. Why? Because of the high suspicion, and there was this culture negative pyuria. CT scan showed that uretrovesical junction stone was 6.5 millimeter. We started on nifedipine, and within 3 weeks, the stone was gone. The child was doing well. This is a very recent one. If you can I'm not sure whether you can see the dates, but this happened, I think, last month or the early this month only. And on proper stone workup, we find that the child was having hypercalciuria and hypocytituria. It is important here to mention that always look into the urinary 24 hours urine creatinine, because that will tell you whether the collection of the urine was sufficient or not. This child had a normal serum electrolyte and acid-base status, and our diagnosis was idiopathic hypercalciuria with hypocytituria. Idiopathic hypercalciuria is the most frequent cause of hypercalciuria, but it is a diagnosis of exclusion. So you have to exclude hypercalcemia, you have to exclude the tubular disorders where the hypocytituria is quite common. And I already mentioned one, the distal RTA. Management is standard, as we already said, that increase of water, low salt, and a lot of potassium citrate and thiazide often required. Next child, a very interesting one, a 9-year-old boy was admitted with vomiting and at 36 hours anuria. Creatinine was sky high at 9.6. Ultrasound showed the left kidney was cross hydronephroureterosis. Right kidney was mildly hydronephrosis. CT scan confirmed that, as well as confirmed a stone at the left vesicouretery junction obstruction. You can see it in the cursor. So they proceeded with bilateral ureteric stenting, which reduced the creatinine, and then it was a standard procedure of left ureteroscopy, laser, and double J stenting. I don't understand this. The radiology department did some fancy thing, gemstone spectral imaging by the GE, and they said that your child has cystinuria. We then examined the urine, and lo and behold, the child did have a cystinuria. This was an 11-month-old male boy presented with sudden onset of anuria. If you look here, that the family has 2 girls who are doing well, and an earlier boy had also died from CKD. The child was irritable, but no other systemic finding, and the creatinine was slightly high. Everything else was okay. Initial ultrasound showed just a mild left hydronephrosis. So despite anuria, there was just a mild left hydronephrosis. If you remember, this earlier child also had a gross hydronephrosis on one side, with the stone was blocked, but the other kidney was normal. And then we said that, okay, let us look at by a linear probe, and this linear probe showed bilateral ureteric stones. Went for a bilateral nephrostomy, good urine output was there. Rest of the management was, surgical management was uneventful, but on workup, we found this child has a proteinuria and a hypercalciuria, and also has an increased urinary beta-2 macroglobulin. I'm sure all the pediatric nephrologists already have the diagnosis here. The child was having Dane's disease, and it was subsequently stamped on genetic analysis. Now, sorry for this type error. Why did so? If you remember, and if you have heard carefully, the cases 2 and 3, both of them became anuric, but with minimal urinary dilatation. So anuric with minimum urinary dilatation, if you're producing, if your kidney is working and there is a block, then you will be having hydronephrosis. So why wasn't there any hydronephrosis or significant hydronephrosis there? There were no hydronephrosis in our last child, and the earlier child, there was a hydronephrosis on the child that the side that had a stone block, but not on the other side. And this is something called the reflex anuria, which is quite common but underreported, is a cessation of urine production caused by stimulus on kidney, ureter, or other organs. And both of our child was having this. And it is a physiological concept, so it gets better by itself. This was a 17-month-old boy with bilateral multiple stones, but no dilatations of the renal pelvis or ureter. And the oxalate was normal. Here comes the other main teaching, that always look at as per the age. So when we looked at the age, it was very high, and we then did a genetic analysis, and it was positive for HOGA1. So this child had a primary hyperoxaluria type 3. This was a child of a doctor, and I'm sure all of you already have a diagnosis with a normal anion gap, metabolic acidosis, failure to thrive, polyuria, and nephrocalcinosis, and a urine pH more than 5.5 on acidification. This was a distal RTA, and it was stamped by a genetic test also. And supplementing, correcting the acidosis resulted into a improvement in growth. So the various common metabolic causes of stone, when should we suspect it? If there's a family history, recurrent history, multiple stones, bilateral stone, associated electrolyte acid-base problems, and associated failure to thrive. And I haven't put up a slide here, but now there is a push for subjecting these children with the nephrolithiasis to NGS. And studies have shown that they do have a good positive outcome from this NGS. Last child, a 2-year-old girl, admitted with high fever and urine plenty of pus cells. Ultrasound showed a single kidney with gross hydronephroureterosis, and you can see a stone at the vesicoureteral junction. So being a single kidney obstructed, went for a nephrostomy, and subsequent workup showed a vesicoureteric junction obstruction, required reimplantation. Stone workup was negative. So this is a child where the stone was because of congenital anomalies. I just reviewed the last couple of years. We have seen about 33 children with stones. Most of them did have a stone workup done, of which 45% came as positive. And we also had a hypercalciuria as the commonest and cystinuria as the next common. And most of them were managed conservatively with surgical requirement for 3 children. So in conclusion, kidney stone nephrocalcinosis are the symptoms of a disease, not the disease itself. Many of them will have a positive family history. Many of them will have an underlying metabolic abnormality, and that's why it is very important to look for them. Unexplained sterile pyuria, as was seen in our case, can be a sign of urolithiasis. Nephrocalcinosis, as was in the doctor's child, can even be asymptomatic. So he was not having any problem from the kidney point of view. Calcium deposition of torn horseful protein are harmless. This I didn't mention in my slides, but they can mimic nephrocalcinosis in neonates. So it is very important for the pediatrician to know about it. And metabolic stone workup should be performed in 24-hour urine collection, but you should avoid doing it immediately after a stone has been passed or in UTIs because they will have wrong results. So thank you for this, give me this opportunity. Thank you very much.
Thank you, sir. Thank you very much for the insight of the talk. It was a wonderful session, having the same topic in 3 different angles. And yours was a wonderful talk, sir. Thank you so much. We'll now take up the questions. So you wanted to hear the questions. You're able to visualize? Rajiv,
yeah, I can. Yeah, I can. So
you just have to go to the full page.
Full page?
Yeah, like on your right, you have the full screen view.
I can see the question anyway. So,
okay, sir. Then you can.
So most of them are. The first one is a comment primarily. So this is a question that in type 1 hyperoxaluria, GFR 60, is it advisable to only do liver transplant? Can we expect the normal renal function after the liver transplant, and how much the percentage? So I think it was covered by Dr. Chandrasekaran, but if you can just, Dr. Chandrasekaran, if you are around, if you can just cover this again.
I think, GFR 60 still patient is not, we don't know when the patient is going, whether the patient is going to progress or not, when it is going to progress, right? I differ. I think the surgeon, what I do is, it's only a small enzyme defect. For that, we have to remove the entire liver, right? At this stage, I don't advocate undergoing a liver transplant with 60 GFR, probably going to 30 to 45. Say stage 3B, I think it is advisable, because it is going to take, we don't know how long it is going to take for the patient to reach the stage 3B. At 60 GFR, I don't think, and I think Naresh, remember we did a preemptive liver transplant for a child less than 2 years with a creatinine of 1.6, 1.4 to 1.6 with nephrocalcinosis, and we had seen after 6 months or so even the resolution of nephrocalcinosis, and the creatinine reached around 0.8 to 0.9. Do you remember, Naresh?
Yeah. Yeah. I think probably the rate of decline of the GFR, because once the GFR starts declining, the more the bones deposits. So we have to be a bit cautious, because if you are going to wait for a very long time and then do isolated liver alone, then it will flush out all the oxalate from the bones. So we have to be a bit cautious. Probably I would say between 45 to 50. I think we should go for a GFR of 45 to 50. We should go for a transplant. Isolated liver transplant.
Karthik, in one of his slides, he advocated for isolated liver transplant. He projected some data.
Yeah.
But I just differ with you, because unless the patient is there is an absolute indication, I don't think I'll proceed with combined in the preemptive liver transplant, and with the attendant risk of transplant. You know, the recent advances has minimized the morbidity and mortality, but going with the living donor transplant, as you said, we are more with the liver cadaver transplant is happening very less, more of a living donor. So for a small enzyme defect, taking the native liver from the patient and also putting the donor at risk.
Yes, so I would completely agree with this because but the current evidence still has not come up with a number at which we should go for a preemptive liver transplant, and GFR 60 might be a bit too early, and
Yes.
Maybe around GFR, as Naresh said, 50-40, we can start thinking of it, and then
we'll know down the line in 2 years it has come down to 50. We know that in 2 years time what is going to happen. So this is the rate of declining will give a very good
that will be also important.
We can take the call.
And as the speaker was saying that with lumasiran, things might change in near future.
No, the cost of lumasiran, cost of lumasiran is important. See, it.
That was one of my questions. That was one of my questions. I don't know what's the cost.
Yeah, as of now, it is 2.4 lakh US dollars per year. 2.4 lakh US dollars per year.
Wow. So something like eculizumab or maybe
200.
more.
No, I think all the orphan drugs are quite costly. Even NTBC for the sake it's costly. 2,500, 2.5 lakhs means 250,000 USDs. Am I right?
Per year. We are not going to stop in a year, right? So
yeah, and we are comparing to a cost of transplant which is 40,000 USDs.
So we go to the next question. This is
here you have to be on lifelong, right?
Yeah. So we go to the next question. It is how to estimate systemic oxalate load. So anyone of you can take this. How to estimate systemic oxalate load?
Okay. I think recent reports, there is like, no, we can, previously they were doing a radio level, carbon tagged infusion of carbon tagged radioactive material was injected, and it's a tedious procedure, more than 6 hours of IV infusion, and they measure the systemic load. And recently we can use a simple glucose strip, or what we use simple glucose oxidase impregnated strip. With that we can infuse oxalate oxidase and then infuse the blood, and you can see there will be a hydrogen peroxide generation, and you can, according to the quantity of oxalate in the blood, it can give you a color change like what you measure glucose.
Okay, that is useful.
But I don't know, that's a quite valid method because it will be in the bone reservoir and all sort of to estimate how much is sitting in the bone.
It's very difficult.
Difficult to estimate the load.
So the next question is that after combined transplantation, what are the next steps for reducing the dose of pyridoxine and citrates of potassium?
I don't think there is no need for pyridoxine after a liver transplant, because you are supplementing the enzyme, right? A deficient enzyme. And it is used only for primary hyperoxaluria. So once you transplant the liver, there is no need for any pyridoxine. And depending upon the oxalate load, and as we already discussed, the oxalate excretion is going to be there for years together. So whatever we have to reduce the we have to alkalize the urine, and we have to use the crystallization inhibitors like potassium citrate probably for an extended period of time.
Yeah, because as you said that it takes some time for the urine to be completely free of oxalate, even if the procedure is successful. There's another comment and question about this combined liver, indications of combined liver kidney transplantation is saying that certain genetic forms of amyloidosis like fibrinogen gene defect may be an indication for combined transplant. Anyone has experience in this clinical context? I have not even heard about it. So you people might be better.
No, I haven't.
Anyone?
No,
okay.
sorry.
I think it is more on the, must be on the adult, because we don't see that much of amyloidosis anyway, that commonly.
Sir, you have any experience on that?
No. It's you know, it is familial, I think. So alpha 4 fibrinogen gene defect leading to amyloidosis. So I know experience, only theoretical knowledge. So they even do a preemptive liver in this situation also. So it's only theory what I know. No experience. Alpha
Okay,
4
there is one question.
Yeah,
sir. There is one question which has already been answered, so it is not popping in the new question list. The question is, question from Dr. Manoj Matani, can you please explain the difference in simultaneous and sequential transplant for hyperoxaluria?
Okay.
VP sir, can you take up the question?
Yeah, it's okay. Simultaneous is you do the liver and kidney at the same sitting. Sequential is the liver followed by the kidney. Okay, so there are indications. Both are combined liver. Simultaneous is at the same time. Sequential is one following the other.
Probably he wants to know the advantage over the other.
I think we already discussed. Okay, simultaneous is see, in cadaver we always do a simultaneous transplant. In patient with some amount of residual renal function like a GFR between 15 to 30, you do a simultaneous. When the space is here, even the time is a bigger space, if it is going to be two different donors, we do a simultaneous. And in case of some cases of severe infantile hyperoxaluria, we can do a simultaneous. For a sequential, we do it in patient with severe systemic oxalates and they have an oxalate load, so that you do a liver transplant, halt the production of further oxalate, do a aggressive dialysis, minimize the oxalate load, and then do a kidney transplant. Or in the same donor is going to donate both the liver and the kidney, you just go with the sequential. And also in some cases of infantile hyperoxaluria also, you can go in for sequential liver and kidney.
So this question is for all of you. Like, so which one do you prefer? Suppose you have a child coming to you with primary hyperoxaluria and has a CKD stage about say 15-20, but still not requiring dialysis. So would you go for and there is a live donor, so mother or father wants to give it, would you go for a simultaneous or would you go for a sequential? Dr. Naresh or Dr. Chandrasekaran?
Okay. Yeah, child with
Dr. Karthik, you are not audible. I think you have to unmute yourself and speak.
Yeah, there are two things which needs to be considered. One is the systemic oxalic load. And if the systemic oxalic load is quite high, then we would prefer to a sequential first and then wait for the oxalate load to clear, which even can take few months, and then put in the kidney so that the kidney graft is preserved here. And you are saying you're given a situation where patient is still not on dialysis, right? So that means you just assume that, correct? The patient is not on dialysis yet, right?
Yes.
So
not on dialysis.
By doing a sequential liver first, later there are also chance that, the kidney might recover and nephrocalcinosis can be halted. And also there is a reversal also has been proven in sequential transplant. So considering these two benefits, sequential transplant the liver first. But however, I'd like to get comments from Dr. Naresh and Dr. VC as well on the same.
Yeah, okay. I mean, also like theoretically it sounds good, but then does that do the family agree to it? Does that increase the cost? All these things can be a factor also. So Dr. Naresh?
Yeah, I think a lot of factors play. As I said, I think we need to have the donors, whether if it's going to be 2 donors coming up or if it's going to be a single donor. If there's going to be only 1 donor, we have to go only for a sequential. If it's going to be 2 donors in the family, we can do straight away. And also sometimes the size of the baby, if it's small, putting up 2 organs, if the liver is too big, and then sort of from the surgical side, the surgeons might feel that it might be an issue for a kidney to put in as well. In this scenario, I think I would agree that a sequential would be better if there is a urine output, because fluid overload is one of the important issues post-transplant. Post-liver transplant, if the child is passing urine, we are quite happy because managing the fluid is quite easy for us. So it gives us some time for things to we can try and see whether they are clearing the oxalate as well, if they are still passing urine. But if the child is not passing urine and on dialysis, then probably we need to think of whether it's sequential. Then comes a debate on overload and losing kidneys, logistics, which logistics is good. So a lot of factors play here. It's not just single factor.
Yeah, I differ with. Yeah. I differ with Naresh. Whenever feasible, if the feasibility is for a simultaneous liver kidney transplant is there, I rather prefer a simultaneous, except for 2 different, except for the same donor, or spacing is an issue. Because I think in our own experience also, we had quite a few patients who lost their life waiting for the kidney transplant to happen, having only the liver transplant. The procedure has been done primarily for the kidney disease and doing liver, and without even getting a kidney. We have lost quite a few patients. Maintaining them on dialysis is going to be tough, right? So an immediate graft function, immediate kidney graft function is more important in any liver transplant patients, right? So unless the space is a constraint, if the same donor is going to donate both the liver and the kidney, I would rather, even though systemic oxalate load, the dialysis is not going to remove whatever, as we had said, the clearance with the dialysis. I think patient has to be on 24 hours on dialysis every day to get a negative oxalate pool. Even though there is no new formation of oxalate, there is resolubilization of oxalate from the systemic tissue. It's going to be more. So I would rather, whenever indicated, I would rather go with simultaneous rather than sequential.
You're more a combined person than a sequential. You're always for a combined procedure.
I think we have covered most of the questions, and we are already overdue. So I'll take the liberty of Dr. Kalaivani and ask a couple of questions, and then we can stop. One was for Naresh. So you use a steroid in these cases or no?
No, we use steroid. I think standard protocol as per liver transplant, we use steroids.
And you stop it when, like early stop, like within few months, or you?
Within, I think we start with 2 milligram per kg at the time of transplant. And we start weaning within every 3rd day we start weaning. By the time the child get discharged, the child will be either in sort of 1 milligram of Vislone or no steroids at all.
No, so do you stop them ultimately, steroids?
I think the liver transplant has, I think King's College sort of continues the steroid lifelong, a small dose, while Birmingham group sort of stops it. So that is the basic, I think there is no yes or no. I think just because we are from King's, we continue with 1 milligram of steroids lifelong. Okay. I think they say...
You're talking with isolated liver transplant, or are you talking for isolated liver transplant or combined liver kidney?
Combined.
Okay.
Basiliximab.
Basiliximab, kidney we are doing, we give it.
Basiliximab.
No, Basiliximab
we do use it. Simultaneous cadaver, mostly simultaneous we do only in cadaver. Living donor, because it is 2 different donors, we use Simulect. Definitely after liver reperfusion, once the duct is done, before starting kidney anastomosis, we do give. day 0 and day 4.
And my other question was for Dr. Chandrasekaran. Like in the absence of genetics, how do you differentiate between pH1, pH2, pH3? Like all those urinary workup, is it available easily? Because I have tried to do it, and most of the centers say that they don't do the urinary workups, like the urinary glycolate and all those things. So without
it's not easily available. Only thing is you have to do a liver biopsy, then I look for activity. I think we are not doing it, it has to be outsourced.
And this that was the other question. The liver biopsy also, when I asked for it, they said that in India they are not
we are
doing
not doing outsourced to Germany.
No, liver biopsy has to be snap frozen and sort of sent. It's practically impossible to do that. I think that's an impossible task because it has to be frozen and -80 it has to be transferred for enzyme analysis.
Yeah,
which is practically not possible.
Exactly. So then I understand that genetic plays a very important role, right, in India, because
yes.
Okay. Any other question from anyone? Otherwise, we can all call it night. It will. Okay. Thank you very much to all of you. For me, at least, it was very, very illuminating. So, Dr. Kalavani, it is all now over to you.
Thank you so much, sir. Thank you, Dr. Chandrasekaran. Thank you, Dr. Rajiv Sinha. Thank you, Dr. Naresh and Dr. Karthik. It was definitely an enlightening session, and there are a lot of gray areas in nephrology. I think this topic is one of its kind. Definitely, it is a gray area, and you have enlightened us with all your knowledge. Thank you so much. Thank you all.
Thank you.
Thank you very much. Thank you.
Thank you very much. Thank you.
Thank you, sir.
Bye.
Bye, sir. Good night.
Good night.